Welcome to the Old Dominion EMS Alliance's training on field triage. What this training provides is an overview of the field trauma triage scheme that's available in the trauma triage plan as well as the ODEMSA protocols. We talk a little bit about mechanism of injury as well as high energy, and we also briefly go over GCS. So what field triage is not is the MCI triage that you do, the START triage or whatever program that we're currently using. So this is not to be confused with that type of triage. This is how to triage a trauma patient either to a trauma center or can they go to a regular facility. The ODEMSA field triage scheme is based on the CDC field triage scheme. The goal of this decision scheme is to transport patients to the most appropriate facility. The question is, what would happen if all trauma patients, all injuries, were transported directly to a level 1 trauma center? And the answer is the level 1 trauma center, which right now is VCU in the ODEMSA areas, our only level 1 trauma center. They would obviously be way over inundated with patients. So we have several levels of trauma centers which take the burden off of the level 1, as well as we have this decision scheme which patients need to go to a trauma center, a level 1, 2, or 3, and which patients can ultimately be transported to the closest or the patient's choice of facility. Before I get into the decision scheme, just ask yourself, what do severely injured trauma patients need? We talk about IV fluids. Do they need an IV? Do they need IV fluids? And the answer a lot of times is no. They don't need an IV. An IV is probably not going to save a trauma patient's life. We may be able to give some fluid and keep their pressure up a little bit. That might be appropriate, but ultimately that trauma patient doesn't need an IV. The point is, if you're waiting on scene for an ALS provider to start an IV, you're not doing your trauma patient justice. That being said, do a trauma patient necessarily need a paramedic? Not really. Trauma is, for the most part, a BLS skill. Those patients need to be stabilized appropriately on scene, such as their ABCs. And a lot of times BLS maneuvers work. For airway, if they're not breathing adequately, we ventilate, and then we control any bleeding that we can with direct pressure and tourniquets. And don't forget to provide that trauma patient with high flow oxygen and keep them warm. These are all BLS skills. Occasionally we'll have a trauma patient that will benefit from a paramedic, but the point of this is that trauma patients, they need a trauma surgeon. They don't need IV. They don't necessarily need a paramedic. They need a trauma surgeon. So if we can manage that patient, get them off of the scene, obviously we're going to stabilize ABCs appropriately in the primary assessment, but then we need to get that patient off the scene into a trauma center. If we wait for ALS, things like that, or wait a long time for maybe a helicopter when we could have maybe transported the patient by ground quicker, we're not doing that trauma patient any justice by waiting for some care that they may not necessarily need. Now, having said that, there are some instances where a paramedic or ALS is going to be the appropriate choice. Major airway issues, burns that we may have to preemptively intubate the airway, things like that, tension pneumothorax. So the point is that for that first piece of the trauma triage, if the patient is unstable, you can't get an airway, they have some sort of airway obstruction, profuse bleeding into the airway that you just can't control, or uncontrolled bleeding that for whatever reason you can't stop, or they're in they develop cardiac arrest. Those patients should be taken immediately to the closest facility, and with the understanding that that's not always a trauma center. So yes, trauma patients, they need ultimately a trauma surgeon, but if we can't get them there to that trauma surgeon, then the closest facility might be the more appropriate destination. So when we look at the trauma triage scheme, decision scheme, we'll see several boxes or tiers. Tier 1 takes into account the vital signs. So if you notice there's 3 criteria for vital signs on the first tier. First we have GCS, then the systolic blood pressure, and then the respiratory rate. So GCS of equal to or less than 13. So basically 14 and 15, we're going to go to the next box. GCS of 13, you automatically go to a level 1 or a level 2 trauma center. Systolic blood pressure less than 90, we go to a level 2 or 3. I'm sorry, a level 1 or 2. Respiratory rate less than 10 or more than 29 for adults. That goes to a level 1 or level 2. And then here is if it's more than 20 for an infant, or any patient really that needs ventilatory support, we're going to need to take those to a level 1 or 2. And then of course we'll get into the piece about children. Should be preferentially triaged to a level 1 trauma center that has pediatric capability. So tier 1 patients go to a level 1 or 2. Before we go on to the other tiers, we'll just take a minute to review GCS. So as we know, GCS is the coma scale that we use. It does have some controversy around it. Is it very accurate, or is it very give a good indication of the outcome of our patient? However, right now that's really the best way, the only way to communicate to the receiving facility and in our documentation to further on down the continuum of care exactly how that patient's mental status was on scene. So GCS is above and beyond the ABPU. ABPU is a very quick, down and dirty way to get a mental status. GCS is actually a test that you need to do. So actually do the GCS. Actually perform the GCS. We have a lot of providers that almost just grab out some numbers and they don't actually take a few seconds and obtain a GCS. Remember that GCSs can change. We can have a good GCS and they decompensate to a bad one, or we can have a bad one on scene and they actually improve. Remember that really pre-hospital, especially the first GCS that we get, we need to really communicate the best score. And what we mean by that is we need to reverse any reversible causes. For example, the patient's been in a car accident, maybe they're knocked unconscious or whatever, they don't have the best airway, they become hypoxic. We get there, they're unresponsive, maybe because they're hypoxic, and we open the airway, we provide them with some ventilation, with some oxygen, we the brain starts to regain function with the improvement of oxygenation, and maybe their GCS, their level of conscious actually improves. So in those situations, we're going to want the best GCS. Another example, a diabetic patient has a low blood sugar attack. They crash because they're not really responsive, and then we get there, we find that their glucose is low, we give them sugar, they wake up, we their their GCS really wouldn't be what it was when we got there. We really want to know what that GC is after we gave them the sugar. Now, if we gave them the sugar, we corrected the hypoglycemia, and they continue to have a poor GCS, then that is much more important, obviously, than the fact that they had a poor GCS with hypoglycemia. I think you get the idea. Also, try to get a GCS before you give any type of sedation, and especially RSI, because we want to know, and the hospital is going to want to know what that GCS was before. A GCS of 8 on scene is going to be a lot better than a GCS of 3 on scene. So just to go through it real quick, and I mentioned to actually take a GCS because I've personally had a situation where the patient's eyes were closed, they did not make any sounds, and some of the providers incorrectly gave that patient a GCS of 3. However, I figured out that that the patient was able to listen and actually follow command. So their eyes were closed, they had no verbal, so a 1 and a 1, and then their motor function, they could show me 2 fingers or squeeze my hands when I asked them to. So they were able to obey command. So they had a GCS of 8. Obviously that's a lot better than that 3. So let's go through the GCS. It's broken into 3 parts: eye response, verbal response, and motor response. Another way you can remember EVM 4, 5, 6. That way you can remember the best for each category, and then you can tease out the different levels if you don't have access to have this written somewhere, so you don't have to remember it. But or in our tough books or our programs, we should have this where we just click, so it makes it a little bit easier. But eyes, it looks a lot like ABPU. The difference here, ABPU, we're looking for any response. So we shout at them and they moan, they open their eyes or whatever. That would be a verbal on the ABPU. However, with GCS on the eyes, we're just looking for eye movement. We want them to open their eyes. So if their eyes are open spontaneously, they get a 4. If we have to shout at them and keep talking to them, keep asking them to open their eyes, that's a 3. If we get there and their eyes are closed and we say, hey, could you open your eyes? They open their eyes, they keep them open, then that would be a 4. But if we keep having to talk to them to get them to open their eyes, then that would be a 3. If they only open their eyes to pain, then that's a 2. But if they have no eye opening to pain, then that's a 1. Verbal response is also fairly easy. We do a fairly good job with this. Of course, this is for an adult, but 5 is the highest. They're oriented, usually to person, place, time, president, those types of the A&O times 3, 4 questions that we ask. And then confused would be they have a confusion, but they're still using appropriate words to answer the questions. For example, what day of the week is it? And they say Tuesday when it's not, or what year is it? And they say 1999 when it's really 2006. That would be confused. Who's the president? They say Eisenhower. They're confused. That's different than inappropriate words when they give an answer that is not appropriate for the question. What year is it? And they say strawberry shortcake. That would be inappropriate words. And then 2 is incomprehensible sounds. So those are mumbles or grunts or moans, things like that. They make some sort of sound when you either talk to them or give them some pain. So that would be a 2. And then of course no verbal, no sounds at all. That would be a 1. And then we go into motor, and honestly, this one's the trickiest one. Um, and the reason is because if they don't follow command, then we have to give them some pain. So if they obey command, they either show us two fingers or blink their eyes. Remember that, consider that your patient actually may have some paralysis, and try to see if they can obey command by maybe blinking their eyes, something like that, should you suspect or have a possibility of a spinal injury. So can they follow command? And also avoid sticking your hands in their hand or your fingers in their hands to ask you to squeeze, because that can actually give a reflex. If you place your fingers in their palm, that actually might stimulate a reflex and cause them to grasp. So do something a little more meaningful, like show me two fingers, or give me a thumbs up, or blink your eyes. So if they don't do that, if they can't do that, then we do need to give them some pain. So if you see in each of those, it says localize to pain, withdrawal to pain, flexion, extension to pain. So we need to give them some pain, and specifically, we need to give them not a sternal rub, but we actually, and maybe not necessarily the Vulcan death grip, but we need to squeeze their trapezius muscle. So if you squeeze their trapezius muscle and their hand comes up and tries to push your hand away, or their hand crosses the midline, then that would be localizes to pain. They get a 5. If they make some sort of movement that is purposeful, and they try to pull away from your pain, that would be withdrawal. Now, when you elicit that pain, and they give that abnormal flexion, that posturing flexion, or the posturing extension, the decelebrate posturing, that would be a 3 and a 2 respectively. And then no motor response, obviously that would be a 1. So do your GCS. Actually take a moment to do it. If they have a 1 for eyes, a 1 for verbal, don't assume that they have a 1 for motor. Actually ask them. Try to elicit some sort of command that they can perform to see if they have a 6. Don't assume that they have a 1. In respirations, actually take a respiration. Get a respiration, see actually what their respiratory rate is, instead of just writing down 16 or 20 that we do. So if they meet tier 1 criteria, you don't need to go to the other tiers. If they have a GCS less than or equal to 13, systolic blood pressure less than 90, respiratory rate less than 10 or more than 29, then they meet tier 1 criteria, and they go directly to that trauma 1 or trauma 2, level 1 trauma center or level 2 trauma center. All right, so after tier 1 patients, if they don't meet those criteria, then we go on to assess the anatomy of the injury. Tier 2 patients, we're assessing the anatomy of the injury, and this is specific to what types of injuries do we automatically take to a level 1 or a level 2 trauma center. And from the list here, you see penetrating injuries to the head, neck, and torso. That's an automatic go to a level 1 or level 2 trauma center. But also extremities proximal to the elbow or knee. Also, chest wall instability, deformity, for example, like a flailed chest. 2 or more proximal long bone fractures. So maybe not the fib tib or the radial ulna, but we're talking about humerus, femur, things like that. Any crushed, degloved, mangled, or we have a pulseless extremity, that can go to a level 1 or level 2. Amputation proximal to the wrist or ankle. And again, we'll talk about proximal. So maybe a finger amputation, you could actually take that not necessarily to a trauma center. Pelvic fractures, skull fractures, and any paralysis that needs to go to a level 1 or a level 2 trauma center. So again, talking about the difference between distal and proximal. Distal is farther away from the body. So an injury right here is distal to the elbow, but proximal to the wrist. So let's just look at a couple of these cases. We have a penetrating trauma to the wrist, and this again is assuming no tier 1 criteria. If they have tier 1 criteria, we would never get to this part. So no tier 1 criteria. What is that penetrating trauma to proximal to the elbow? Not necessarily a level 1 or 2. Sure, you can take that patient there, but that patient could go not necessarily to a level 1 or 2. And then here is the penetrating trauma proximal to the elbow. That needs to go to a level 1 or 2. Amputation here to the finger. Again, not necessarily to a level 1 or 2. Amputation, that actually needs to go to a level 1, and we'll talk about that in tier 4. We have penetrating trauma to the leg, distal to the knee, and then penetrating trauma to the thigh. That needs to go to a level 1 or 2. And of course, penetrating trauma to the torso, that's a level 1 or 2. To the neck, 1 or 2. Assuming no criteria, what does this patient need to go to? And that would be a level 1 or 2. Mangled extremities, that goes to a level 1 or level 2. Pelvic fractures, level 1 or 2. Alright, so step 3, or the tier 3, is where we look at mechanism of injury. Specifically, what we're asking, is there high energy in the mechanism? So we can look at a few pieces of criteria that says this is probably high energy or not. So if we remember from our EMT class, we remember that kinetic energy is equal to 1/2 the mass times the velocity squared. So we're talking about the energy of motion. Kinetic energy is equal to 1/2 the mass times velocity and squared. And that's where this is really important that we have that velocity squared. So again, m is the mass of the object. So a car, you have a object that's 2 tons going 60 miles an hour. You can calculate what that kinetic energy is. And then v is the velocity or the speed of the object. What this means is that if we double the mass, we're going to double the energy. If we take that 1-ton automobile and now we make it a 2-ton, we're going to increase the energy by 2. Double the energy. But let's say if we double the velocity. If we take that 1-ton car and now we're going 120 miles an hour versus 60 miles an hour, we're not going to double the energy. We're actually going to quadruple the energy. So when we're really looking at mechanism of injury, one of the most important questions, how fast were they going? We also look at what is the height of the fall, because we're going to speed up as we fall. As we accelerate due to gravity, we're going to speed up, and so we're going to look at the height of the fall. The higher the fall, the more space we have to speed up before we hit the ground. We're going to look at the maybe not necessarily the speed, but we're going to look at the car. Does it have evidence of high energy? A a um, a high speed penetrating object such as a bullet versus a knife. It's going to have more energy because it's going faster. So what happens with that energy? So Einstein says energy cannot be created or destroyed. So that energy, if you're going 60 miles an hour down the road, you have a certain kinetic energy. You can't it can't just disappear. If you have to come to a complete stop, what do you have to do? You have to hit the brakes. And the brakes cause friction, which cause heat. So that energy is actually lost to heat. So we convert the energy, the kinetic energy, to heat between the brakes, the tires on the road, etc. So the kinetic energy has to go somewhere. We can't just delete the energy. So here's you have an example of a car. You see the brakes are heating up. So if we have enough distance to stop, we can apply a little bit of pressure to the brakes and dissipate that energy as heat over a long distance. If we have to slam on the brakes and we have a shorter stopping distance, what happens? We kind of buck forward in the seat. Our coffee spills all over the dashboard, etc. Everything that we have in the front seat is now on the floorboard. So it's not a controlled stop. That energy has to go somewhere. So that computer that's sitting on your front seat is still going 60 miles an hour when you hit the brake really hard. Now it's thrown to the seat until it comes in contact with into the floor. So the kinetic energy has to go somewhere. All that energy goes somewhere. In this case, if we have enough stopping distance, it goes into heat from the friction of our brakes and the tires and things like that. But what if we don't have enough stopping distance and we hit something? Well, that energy has to go somewhere. So that energy goes into crumpling the car. It takes force it takes energy to make those dents in the car, to break the glass, etc. So to twist that, you see the tire is twisted around from where it's supposed to be. So that takes a lot of energy to deform the automobile, and that's what it's designed to do. It's designed to take that energy and change it from kinetic energy to bending and twisting the metal. Now we hope that's what happens. If we have an old car that's like a tank and you hit it, just bounces off, that energy has to go somewhere. Unfortunately, that energy is going to go right into and through the patient, and as the energy goes through, it's going to put stress on things like bones and vessels and organs. And if it's high enough, if that energy transfer is high enough, we're gonna get injured. So tier 3 is assessing for evidence of high energy. So again, falls, we're looking for the greater the height, the more energy they're going to have. And generally the cutoff is about 20 feet for adults, or 2 to 3 times the height of the child, if it's a child. For auto crashes, high energy. So if there's an ejection, either partial or complete, we're gonna assume that's high energy. If there's death in the same passenger compartment, if there's enough energy that causes someone to die, we're gonna assume that there was high energy that went through that patient compartment, and any other patient in there is we're gonna assume has the potential for injury. Intrusion with 12 inches into the occupant site, or 18 inches in any site, that's going to be enough energy to warrant tier 3 criteria. Um, Pedestrians or bicycles, any impact over 20 miles an hour that, or they're run over or thrown from the vehicle, we're going to assume that's high energy. And then motorcycle crashes more than 20 miles an hour. Now this is where we get into these patients, again, assuming they have no level 1 criteria, no level 2 criteria, then we can transport these to a level 1, 2, or 3 trauma center. So if they do not make 1, 2 tier criteria, and we get to level 3, then now we can take them to a 1, 2, or even a level 3 trauma center. So think about that patient that was there's a death in the same compartment. The driver was killed. The other patient's walking around on scene. Their vitals are good. They don't have any of those tier 2 injuries. I still would transport that patient to a trauma center, and a trauma 3 would be appropriate at that point. Ground level falls, as we mentioned, ground level falls are not a significant mechanism of injury. Ground level falls by themselves are not high energy criteria. However, they may have other criteria. For example, you have that patient that have the ground level fall. Now their blood pressure is 80. Just hypothetically, that would be trauma center criteria. And then the fourth box, we actually get into some special population criteria. So that picture right here with this elderly gentleman, he actually might still be preferentially transported to a trauma center. But a ground level fall by itself is not high energy. We do have 2 level 3 trauma centers in the Dempsey region, and that is Johnson Willis and Southside Regional. So without tier 1 or 2 criteria, these can be transported to 1, 2, or 3 trauma center. So assuming they don't meet any of those, again, if we come to one of the tiers, one of the lines, the decisions, and we determine they need to be transported to a 1, 2, or 3 trauma center, we don't have to go any further. At this point, we've gone through 1, we've gone through 2, and now we've gone through 3, and they still don't meet any of that criteria. Now we get to asking ourselves some of these questions. Any child that meets 1 or 2 criteria above, burns, or a amputation where there's a possibility for reimplantation, they need to go not to a level 1 or 2, but just to a level 1 trauma center. If you have if you don't meet any of those criteria for special considerations, so older adults, so again, these are they don't meet tier 1, they don't meet level tier 2, and they don't meet level tier 3. So we've got to level 4. They had a ground level fall, but they're 65. You might consider taking that patient to a level 3 trauma center. Systolic blood pressure less than 110 may represent shock in patients over 65. And then low impact mechanisms, ground level fall for these older adults may result in severe injury. So this is where we get into special considerations for the elderly population. Also, anticoagulation or bleeding disorders should be transported to at least a level 3 trauma center. Patients with head injuries. Not saying that every bump to the head needs to go to a trauma center, but keep in mind that these patients can deteriorate rapidly, and they may need to be preferentially transported to a 1, 2, or 3. any trauma to pregnancy over 20 weeks, end-stage renal disease, and just your provider judgment if just something is not right about that patient, and you just have that have that sixth sense about that patient, or just that you just thought gut feeling. Take that patient to a 1, 2, or 3 trauma center. So if they don't meet any of these criteria, tier 1, 2, 3, or 4, then you can transport to the closest appropriate facility. At any time, if you are in doubt, transport that patient to a trauma center. So just real quick, the tier 4 did include anticoagulation. So I just wanted to list a few of the more common blood thinners that we have. Of course, there's more than just warfarin. There's all kinds of new ones, like Eliquis and Xarelto are some of the new drugs that we might see. Also Levinox, which is not on here. Some histories, maybe you don't have access to their medications, but if they tell you they have a history of AFib, stroke, previous heart attacks, DVT, pulmonary embolisms, they may be on a blood thinner. So that might be indication right there to take them to a level 3 or higher trauma center. So in summary, any major ABC issues should go to the closest facility, and we mean major. You can't control the airway, you just can't ventilate this patient, or they're bleeding and you just can't control it. The closest facility can at least stabilize that patient, control the airway, RSI, get the patient on the ventilator, maybe even crike the patient, decompress pneumothorax, hang blood, get blood running, and then transfer them to the trauma center. Remember that patient needs a trauma surgeon. So I would be very careful on which patients. If you need to stop at the closest facility, do that. But ultimately, that patient, you have to weigh the delay in getting to a trauma center with the benefit of stopping. Tier 1 and Tier 2 patients go to level 1 or 2. Tier 3 patients and Tier 4 patients can be triaged to a level 1, 2, or 3. Peds, burns, and amputations proximal to the wrist or ankle should be triaged to a level 1 trauma center. When you're looking at mechanism of injury, you're looking for evidence of high energy. Patients not meeting tier 1 through 4 could go to any hospital. When in doubt, if they don't meet 1 through 4, or you're just not really sure, take them to a trauma center. So thanks for listening. Be safe.